let's get this party started. So what we're going to talk about is basic arrhythmias. And this is a sort of, we're going to do 3 questions that you need to answer any arrhythmia. We're going to talk about the 10,000 foot view, and we're also going to kind of revisit conduction and revisit the waves. So this is our topic for tonight. We're going to cover PQRST. We're going to talk about the rules for the waves, and we're going to talk about, let's see, here we go. Hold on really quick, you guys. Let me make sure we're recording so I can send this back out to you guys. Okay, hold on, you guys, 1 second. All right, so what we're going to talk about is what the waves are, the rules for the waves, and we're also going to talk about the big 3 arrhythmias that you need to know that are sight arrhythmias. And we're also going to talk about 3 questions to solve each arrhythmia. But before I get started, I kind of want to know a little bit more about you guys. So tell me in the chat who we have here. Are you basic? Are you more intermediate? Are you advanced? Tell me about, really quickly, type in the chat, what is your level? What is your level of expertise? How comfortable do you feel with arrhythmia recognition? Okay, Megan says she's graduating from PA school. Janice, intermediate. Okay, we have lots of intermediates here. Intermediate. I work in SimSU as an RN. Okay. All right. Janet, okay, so you feel like you're at level 5, NP primary care. Candice is basic to intermediate. Okay, good evening, Melissa Reyes, yay. New grad PA. We have advanced EMTR and Melissa, yes, you are very good at arrhythmias. And Katrina, intermediate FNP primary care. Okay, and then really quickly, what's your 12 lead comfort level? What's your 12 lead comfort level? Okay, so 12 lead comfort level, NP in ID, intermediate in EKG. Okay, retired. All right, Diane, I didn't know you were retired. Janice says, okay, all right, very good. And 12 lead comfort could be better. Timmy says poor. I know, right? It's definitely, yeah, ditto. Okay, so we all have some room to move, room to improve. All right. So let's, same as Stephanie, I could be better. Always like the refresher. Good. We are in Zoom. Okay, so let's get kicked off then. So let's talk about the concept check. And what I mean by that is, what are we actually measuring? So that's half the battle, remembering what we're actually measuring. And if you think about it, it's the same for 12 lead as it is for EKGs. Now I'm going to show you really quick with my big heart. Okay, now this guy, all right, this is the way I like to think of it. He sends signals from inside our chest. And basically, the electrical signals are what we capture on the 12 lead. We also capture these on our rhythm strip. So when we're looking at a 12 lead, we're looking at the front of the heart, but in the rhythm strip, we're just looking at the electrical activity. So the question that we're always trying to answer is, we're trying to answer, did the sinus node still remain in control of the heart, right? So the sinus node, I'm going to show you a graphic. There's 2 ways I like to think about the sinus node, but basically the sinus node is the president of the heart. Okay, so sinus node makes P wave, and sinus node sends the impulse down to the ventricles. And we're looking for a P wave to see if the sinus node is in charge. We're also looking at the way the electricity moves down through the bundles, looking at the width of the QRS. And the other thing we're always looking at is how big is the voltage. Now that's more of a 12 lead thing, which we will definitely go over in our 12 lead classes if you're in the 5-day EKG challenge. But just remembering that that's basically the concept that we're looking at is really helpful. Now the other concept, and this is kind of a funny picture, but when I was first learning about the sinus node, I thought, okay, is there an easy way to think about how the electricity goes down. And you guys know from like basics that, let's see. So basically the rhythm will go from the sinus node, which makes a P wave, down the internodal pathways to the AV node, and it'll get slowed down a little bit. And then it'll go down the bundles. Okay, it'll go down the bundles. And that's normal. Now, if you ever wondered, well, actually, let me ask you, why does the sinus node get to run the heart? Like, who put the sinus node in charge? And also, the other way I like to think about it is like a pitcher, as pictured here. The pitcher throws, right? The pitcher throws the electrical impulse down to the catcher, who's the AV node. And the catcher, as you know in baseball, hangs onto the ball for a second and then does whatever the catcher is going to do with the ball. The same thing is true with the the sinus node. The sinus node sends the impulse down to the AV and it hangs on to it for a second. If you remember that, it helps you understand things like Wolff-Parkinson's White or accessory tract issues because, right, if the impulse is supposed to go down here and get slowed down for a minute, if it goes around the AV node, that's why it can go super, super fast. So getting back to the sinus node. So at the end of the day, why is the sinus node the one running the heart? Well, it turns out the sinus node is actually the fastest. And that's really the answer. It's just the fastest. Oh, Melissa, you're so sweet. But if you're the fastest, then you always get to win. And so the AV node can't take over until the sinus node gives up, right? Because the AV node goes a little bit slower. And it's kind of like that analogy of if there was like a bunch of tigers coming in to eat us and we were all running together, right? The person running the fastest would definitely win. It's the same thing. And so that's kind of helpful to understand. But in addition to that, you also want to think of the waves like a family. And this will help you when you're starting to do heart blocks. So when you have your P wave, the P wave should be holding hands with the dad, R wave, and the dad should be holding hands with the baby, the T wave. And they should all be holding hands together along the EKG. That's what normal is, right? The mom shouldn't be too tall. The dad shouldn't be too tall, right? Everybody should be their own appropriate size. And of course, the baby should be nice and close to his own dad, not running off to his next mom. And that will help you, again, the relationship between the mom and the dad when we're doing heart blocks, which we will have a couple for you at the very end. So when we talk about the basics, and I know a lot of you are intermediate, when we talk about the basics, it is a good idea just to revisit the actual name of the waves. So here's the P wave. And the thing we want to remember about the P is it should be nice and smooth. We don't want it to be notched, okay? And we also don't want it to be too big. If a P wave is notched or really big, a lot of times that means the atria is too big. And if the atria are big, that can lead to other problems down the road, like atrial fibrillation. Now, the next little wave we want to know is the Q wave. The Q wave is the first negative deflection after the P. And then as you go up here to the first positive deflection, you've got the R wave. And then if you cruise back on down, you've got the S wave here. And then you've got our beautiful T wave. So mom, dad, baby, everybody's happy, right? When they're all nice and close together, not too close. And of course, we don't want the T wave to be notched either. And we don't want an extra wave as seen here, which is the U wave. We don't want any of that to be going on, right? Okay, so that's how to find the waves. But how do we do it on the actual strip, right? How does that work? Now, I kind of threw in a little bit of a difficult strip for you here, not to be mean, but just because I wanted to make it a little bit exciting for anybody who's intermediate. So, right, we're always looking for the P, the QRS, and the T. So when we're looking for the P, I always find it helpful to go find my R's first, right? Because they're the biggest and they're the ones that are going to be, they're the ones that are basically going to be the most pronounced. Now, we'll talk about this in a second. This is a good strip to use, but we're also going to look at when we talk about the 3 questions, is it regular or irregular? Okay, is it regular or irregular? Now, we need to find our P. So once you find your R, you go and look right in front of it, and that's where your little P wave should be. Okay, so your P wave is here, P, 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 P. Okay, so we found our P. And let me ask you guys a question. So type in the chat, what do you think about those P waves? Do they look the same? Do the P waves look the same to you? All right, let's see. We've got no. Okay, good. Oh, hey, Chris. Brogna's here. Krista, Christina, and Robin. Okay, so everybody's pretty much agreeing the P waves don't look the same. Okay, I agree with you. So if we're troubleshooting this, okay, if we're troubleshooting this, then tell me if the rhythm is regular or irregular. Now, these little hearts kind of make it a little easier to see. Is it regular or irregular? And the terminology means, does the R wave come at the next expected interval? So here's a little cheat sheet way I do it. Okay, everybody's saying irregular. Yes, you guys are right. Okay, so let's talk about that. All right. So let's do this. Let me show you my little trick. So what you do is you go and you find, this is for people who couldn't see that it was irregular, and that's okay if you can't. But what you do is you find the distance between the R to R, and that R to R is different from that R to R. Okay, so that means it is not regular, because if it was regular, you'd have this beat, this beat, this beat, and then the next beat would come in like right here. Okay, so at the end of the day, this is not regular. So here's the bonus question. This is more for my intermediate folks, most likely, and you guys are all killing it, by the way. All right, so you guys are killing it. But tell me, what is this rhythm? What do you guys think this rhythm is? Also, what do you think this rhythm is? And then what is the cause? This is a little bit more intermediate. Okay, so if you're advanced, don't worry if you don't know this, but okay. So Timmy says wandering atrial pacemaker. I like where you're going with that. I absolutely like where you're going with that. Okay, because the P waves are different and it is irregular, but this is actually, Chris, yes, this is a sinus arrhythmia. Okay, so this is a sinus arrhythmia. This was a hard one. And Timmy, I love where you're going with that because the P waves look a little bit different. But this is caused by, so it's a sinus arrhythmia. And what is the cause of sinus arrhythmias? This is a really good thing to know because sometimes people think this is Afib. Sometimes people think this is Afib, but it's not Afib. And we can get lulled into thinking that. But this happens in young, healthy people. Okay. And so what do young, healthy people? Okay. Yeah. So medication and caffeine, but also breathing. Okay. So breathing can cause this. So at the end of the day, this was a sinus arrhythmia. We found our P, our Q, and our T. And the last thing I wanted to point out is when you're looking at these rhythms, how do you know if a rhythm is coming from the atrium? What's your guys' trick to know if a rhythm is coming from the atrium? How do we know a rhythm is coming from the atrium? P waves are present. I like that. That's a good answer. Okay, we have lots of P's in the chat. I like where you guys are heading with that. Tell me about the width of the QRS. Yeah, okay, good. So a rate around 60, that's usually helpful. But tell me about the width of the QRS if it's coming from the atrium. Okay, good. It's a narrow QRS. That's the secret sauce. Narrow. Good. Cheryl and Janice and Christy and Melissa. So good. This is really, really, really good. Okay, so let's go on to our next one. All right, now the rules for the waves, I'm dropping this really quickly, and I kind of covered it already, but the P wave, right? It should be smooth, upright, and married to the DAD. Absolutely. Okay, the QRS should also be not too big, not too small, because when we're thinking about the the depth of the QRS or the R wave, we're again asking that question about voltage. How much muscle is there feeding to the chest wall, right? We don't want it to be too low because then we worry about things like pericardial effusion. and we don't want it to be too high because then we worry about things like LVH, okay? And then also the QRS complex, it shouldn't be too wide, which we talked about. We should always want it to be narrow, meaning it's coming from the ventricles. And the T wave, there's a little secret. The T wave should be upright in all the leads except for AVR and V1, but it should also be a little asymmetric. And symmetry is really important when you're talking about T waves. So then there's this concept that with sight rhythms, okay, there's 3 rhythms that you should know by sight right off the bat, okay, by sight. And these are called the big 3. So there can't miss strips. You have to see it, shout it out, and know it. So we're going to do a little pop quiz for you guys. All right. So ready, set, go. What's this one? So what's this one? This is what? Okay. Oh my gosh. Good. We have some folks chiming in. Yeah, good job. So everybody's like, this is Vfib. Okay. That's an easy one. We know because it's got this irregular. Yeah, good. Yeah, Anoop says Vfib as well. So everybody scored on that one. That was an easy one, right? That was kind of a slam dunk. Good job, Anne, on Zoom as well. All right, now let's give you another one. Okay, ready, set, go. Which one is this one? What arrhythmia is this? If you saw this, would you be worried? Yes, Karen on Facebook is also answering. Okay, Megan says asystole or fine Vfib. Melissa says asystole. Okay, yeah, this one was a kind of a tough one. Anne says asystole, good. Everybody says a flat line, asystole. So that's a good point. And most folks are saying asystole. And the folks on Zoom are saying, and Facebook both are saying asystole. But we do have one fine Vfib. And to that, I'm going to tell you that who said fine Vfib, you could potentially be right. And this one's a tough one, right? Because there is a little bit of electrical activity, but you're probably safest treating it as asystole. Okay, so nice job, you guys. Nice job. Now, this one's easy. Wide, fast, and regular. Okay, good. Yes, you guys all got it. You're all like VTAC, VTAC, VTAC on Zoom. Okay, good. Yeah, you guys nailed it. Okay, good, good, good. And Anne is also saying that it is VTAC. Strong work. Okay, so our question to this rhythm would be, what is there a pulse or not, right? Are they stable, unstable? Is there a pulse or not, right? That would always be our follow-up question to this. Now let's do another one, or another section. So the next thing I wanted to tell you, I mean, my little secret sauce, now that you got the basic 3 sight rhythms you can't miss, is the 3 questions that you want to ask yourself when you have an arrhythmia to figure out what it is. So question number 1, is it fast or slow? Question number 2, is it regular or irregular? And question number 3, is it wide or is it narrow? Okay, so fast versus slow, regular versus irregular, wide versus narrow. Oh, Janice is already on it. Janice already said the answer to this strip. Good job, Janet. Okay, so looking at this, let's do this one together. Okay, if you looked at this, is it fast or slow? And unfortunately, right, this doesn't have an actual rate for us, but we can tell it's slow. Okay, and this one's a tough one because the width, okay, we have a lot of guesses on Zoom. Good, Karen, and Facebook, yes. So we have some votes for junctional and we have some votes for idioventricular. I will tell you that this one is a hard one. So Melissa says, no, P wave, idioventricular. Okay, so I love all the conversation that's happening right now because we're critically thinking about this, right? And I will agree with you guys. I think everybody agrees there's no P wave. So we know the sinus node's not in charge. We also know that the rate is about probably around 40, okay? And we know that idioventricular rhythms are wide, okay? So this, and yeah, idioventricular versus junctional, this is the big question, right? What is it? Because junctional and idioventricular would not have a P wave. Usually idioventricular tends to be, the boxes tend to be, or the QRS tends to be a little wider and it's a little slower. So this one was actually a junctional rhythm, but the way it's drawn, it almost looks a little wide. So I think I would definitely say this is a borderline one. This was a tough one, but this was actually junctional. And the junctional, it runs about like usually 40 to 60, right? And usually the idioventricular runs 20 to 40. So this was in that kind of borderline range. Okay, so then the other thing I wanted to show you really quick was that on an actual strip, here's your P, here's your R, and here's your T. Okay, here's your Q and here's your S. But I wanted to tell you something. You won't always have a Q and you won't always have an S. Sometimes you just have an RS, right? And so sometimes it doesn't continue past the baseline. That can be a normal variant. And the other thing I wanted to point out to you on this is the importance of knowing this segment. Okay, what is this segment called, by the way, you guys? This segment is a very important segment, very, very, very important segment. And it's what we use. Yeah, good. Oh, hey, Samantha, you're here. So this is actually the, right here, it's the ST segment. And there is a QT, Michelle, and it's right here, from here to here, the QT, another important segment. But this guy right here, this is the ST. And this is what we're always looking at to see if it's elevated or depressed. So this one is not. It is nice and normal, but we're looking for any sign of ischemia, right? Elevation or depression. And we don't see that. So that's good. Now let's practice another one here. Is there a P wave? And is it slow, normal, or fast? And
here's what I found.
Siri wants to play. That's so cute. Siri wants to play. But who's in charge of the heart? And is the family getting along? Ooh, Michelle. Okay, Michelle's on it. And Samantha says prolonged PR. Cheryl and Chris, and actually everybody on here that's saying something is getting it right. And also Facebook. This is a first degree block. Okay, so it is a little bit slow, but it is a first degree block. And so what I want to point out to you on this one is just that this, okay, this interval, we're not going to talk a lot about intervals right now, but this interval right here, so beginning right at the beginning of the P to the R, this is called the PR interval. And this should be no more than one big box or 200 milliseconds. So this is definitely too long. And you can tell that the family is not getting along. Yes, Vanessa says family is not getting along. It's mostly the mom and the dad, right? They're just not getting along. The dad's still hanging out with the baby, but the mom and dad are just not seeing eye to eye. Now, first degree blocks, what do we do about them? Not a whole lot. We watch them. We make sure they don't progress, but in and of themselves, first degree blocks are not dangerous. They can progress, right? So we're always keeping an eye on them. Okay, and that was the junctional rhythm. We already talked about that. And this one is another good one for you guys. So the questions are, is it fast or slow? And is it regular or irregular? And what is the baseline rhythm? The key to this, and I know you guys are all going to nail this. No, you are. But the key to this is basically looking at the R to R, okay? And also looking at the baseline right here, the baseline. That's the two clues, okay? So it's not regular. Oh, looks like everybody's in the chat. Okay, everybody is saying Afib. So there's a unifying theme. This is irregular, no P wave. This is Afib. Okay, good. Good job. This is Afib. I totally agree. And again, it's irregularly irregular with a wavy bag of worms baseline and no discrete P waves. And the one thing that's tricky about Afib is that sometimes, and Karen says it's irregular, I agree, sometimes we'll kind of like go, oh, is that a P wave maybe? Yeah, so it's the SA node is not in charge. It's the rest of the atrium that's storming the SA node and has taken over. So when we have the SA node in charge, we'll see a discrete P, but we don't see any discrete P, which is kind of frustrating. And sometimes this can go really fast and be called Afib with RVR. Then you've got this one. Now, just looking at this visually, you can tell that it's going a little bit fast. Okay, so this is a faster. It's a narrow complex, and it's regular. Okay, so it looks like Vanessa got it spot on. She says sinus tach. And then Janie says SVT. Michelle says SVT. Yeah, this is kind of a hard one. We would need to measure out the rate, but I'm pretty sure that this was calculated right at 150. And that's a good, I like that you're bringing that up, ladies. Let's talk about that for a second. So Yeah, okay, everybody's saying maybe it's flutter. Okay, so let's talk about that. To really see if something is flutter, you really want it a little bit faster. This was not flutter, this was sinus tach. But to tell if something is actually 2-to-1 flutter, you really need to look at V1 on a 12 lead. This was not V1, unfortunately. But when it goes fast, around 150, you have to consider SVT as well. You have to consider SVT when it goes really fast, okay? This actually was sinus tach. We can still see the P waves. Usually SVT is going to be a little bit faster. So the differentials will be sinus tach, SVT, and 2-to-1 atrial flutter. However, think about this. Look at your history, and that will often help you too, in addition to a 12 lead. So history, if they just spontaneously came in, they have no volume loss, they're not in pain, they're not freshly off their beta blocker, let's say, in beta blocker withdrawal, and they just spontaneously went into this, okay, that would more likely be like SVT or 2-to-1 A flutter. But if they came in and they've been vomiting a bunch, they're in a lot of discomfort, they're super anxious, sinus tach is more likely because they've got some stimulus, and their heart rate will vary. With an SVT, it'll stay consistently fast. And with Afib, A flutter, it will do the same thing as well. And the other thing that I wanted to tell you is with sinus tach, will usually give you at the top of the 12 lead, it'll give you a calculated PR, where this would usually give you an asterisk if it was SVT or 2-to-1 atrial flutter. Okay, now this one is another fun one for you. This is a really tricky one. So our intermediate folks, this is going to be a good one for you, but I'm going to walk you guys through this. Okay, so the key is looking at this. This one's subtle. It's not regular. Okay, so it's not regular because there's a little bit of variation, and the variation happens right here. This one looks the same, 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 but this one's short. So what's going on here that is actually the problem? Okay, what do we call this? Oh, okay. Yeah, this one's so tough. This one's tough. So Janice has dropped P wave. I like it. PAC question mark. Yeah, this is a toughie. So let's walk through it together. There's actually 3 types of ectopy. There's PAC, premature atrial contraction. There is PJC, premature junctional contraction. And there's PVC, which is premature ventricular contraction. So right here, what you're seeing, this one here, you've got PQRST, 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 no P, just QRS and T. So when you're missing a P, but it's still narrow under 3 small boxes, that can only be one guy who's running the heart. Because remember, and this is a quick concept check, anything that's narrow is coming from above the ventricles. So this can't be a PVC. It is early, but it's not wide, so it's not a PVC. And there's no P wave, so it can't be a PAC. It's got to be the guy in between, which is the premature junctional contraction. These are super rare. You will hardly ever see them. But if you know how to troubleshoot it, you'll never miss them again, right? You'll never miss them. See, I told you, you intermediate folks, I'd have something for you too. Now, this one is going to be easy. I know you're all going to get this. This one is slow and wide and regular. I know y'all are going to get this within like seconds. Let's see. Yep. Michelle and Michelle. Yes. Yes. Okay. So yes, all of you guys got this right. This is idioventricular. Nice job. So we don't know where it's coming from in the ventricles. It's very wide, more than 3 small boxes. It's slow. It's in that 20 to 40 range. Okay. And it's still regular. Sometimes this will have a pulse, sometimes it won't. But again, just being able to spot it, no P wave, and it's wide, no P and wide coming from ventricles. We just don't know where in the ventricles. Therefore, it is idioventricular. This will usually kind of fade on down into more of like an agonal rhythm or asystole as it continues to progress. And hopefully it doesn't progress. So what is this one though? This one's a little tricky. And pretend that you're at a party and we're putting up streamers. What do you do to the streamers? What do you do to them? You kind of twist them, right? You twist the streamers. Yes. Okay. So we have polymorphic vtoc torsades. Yes. Yes, yes, yes. Good. Good, good, good. You guys are so right. Julie's on Facebook. Yes. Okay. This is torsades. It's a twisting of the points. A preceding prolonged QT preceded this. And so we saw this patient go into it. And so this is a twisting of the points. This was a torsades. We treat this a little bit differently than we do a regular flavored vtoc. What medication do we give torsades patients when they go into their cardiac arrest? What medication? I think, oh, yeah, you guys are all over that. You guys said MAG. Yeah, piece of cake, right? Piece of cake, everybody's saying MAG. Nice job, you guys, nice job, nice job. And then we have a couple more for you here. What's going on here? Yes, you guys are all over the MAG. I love it. What is going on here? So this is a problem in the marriage between the mom and the dad. Okay, this is a problem in the marriage. You've got, I'll tell you if it's a heart block. Okay, yes, actually you guys already got it. You guys already said winky bog. Okay, good. Okay, you're right. This is a winky bog. This is a second degree type 1. Okay, let's walk through it together. So here you have your, oh, that's not a good color. Let's switch. Here, let's do blue. You've got your P. That's getting long, longer, longest, and then drop, rinse and repeat. So again, this is a winky bach. Yes, no worries. Type 1 winky bach. Yep, you guys are right. Spot on. And this is a tough one because, right, the whole situation, the whole analysis is based on the relationship between the mom and the dad, right? So the story I like to tell about this is that the mom and the dad, they start having problems and more problems, really fighting. And then they're just not getting along at all, big blowout. And here's the mom, but the dad, he went out and got his own apartment. And, you know, they were chatting about, you know, hey, maybe we overreacted and let's go to some counseling and see if we can work this out. They go to some counseling, they come back and they try again and things are fine again. But as in most soap operas, you know where that goes, right? Things start to decline in the relationship and then there we are again. We rinse and repeat the whole thing. Okay, and eventually that proceeds into a higher degree block, most likely. However, interesting note, I have seen young athletes and people with sleep apnea on their Holter monitors sometimes have winky bach. First time I saw that, I was like, what? This guy needs a pacemaker stat. And to which my cardiologist quickly replied, he was like, actually, this could be a normal variant, that in first degree block. And so it's funny because as a paramedic, anytime somebody was in this rhythm, they usually progressed on to something worse, right? Like my N of whatever was all skewed to everybody dies when they have this. And so he was like, no, actually, not everybody dies. And so it's funny when you go to paramedic and you go on to something else, you're just like, oh my gosh, everybody's going to die, because that's like what happens in the ambulance. People are really sick. That's why they call 911. So anyway, that was kind of an interesting, fun thing. All right, now let's talk about this one. There is a problem in the marriage. I will tell you that. I'll give you a hint. Okay, give you a little hint. Oh, look at that. We got some guesses on Zoom. We got Michelle saying that this is a second degree type 2. I will agree with you. I will agree completely. Okay. And Anoop says type 2. Chris says type 2. Very good. Okay. Can't fool you guys with the heart blocks. Julie's on there saying, what's up? What's up? Okay. So let's look at this real quick. We've got a P, an R, P, R, P, R, P, no R. But when the mom and the dad are together, they're together at the same interval. But occasionally a dad drops out for a second. Okay, so that's a second degree type 2. And again, why our family really matters so much. Okay, good job, Vanessa and Chris, everybody who said on Zoom, good job. Okay, and then this was just another example for you to see a little bit different of another type of heart block. We already covered this one, but what would you say this one is? And you've got drop, long, longer, longest drop. You'd need a longer strip to see it, but it's going long, longer, longest drop. And that is none other than the winky. Janice says, winky, winky. Yeah, that one's a little bit tougher. Okay, so lengthening first degree, or sorry, lengthening, but consistent is first degree. lengthening, lengthen, drop is for second degree type 1. And then consistent PR with dropped is type 2. Okay, good job, you guys. So what is this for the, I think this is almost our final strip. What is this? This one's easy. Let's get some confidence boosted. This is Basic. This is Vfib. Okay. Yeah, we're definitely not going to miss Vfib. I think, although it's funny when I was in paramedic school, the answer to this question was check your patients, check your leads. And we have had a case in the heart center that I wasn't there for, but I heard the story and got to see the strip. So my cardiologist actually showed this to me. And he said, here you go, kid. Tell me what's wrong with the patient. So I look at the strip and it was what I thought looked to be like vtoc. And it was labeled as vtoc, the machine labeled as vtoc. It was pulled out by the nurse as vtoc. So he says, I got summoned to the heart center for this strip. What would you do? I love that game. And I was like, well, I would. He goes, stop. If the first thing out of your mouth isn't go check the patient, then don't even talk to me. I was like, oh, I love this game. And he was so sweet. He wasn't saying it mean. And I was like, okay, my first step is check the patient. He's like, good, that's exactly what I did. And I went in and the patient was brushing their teeth. He's like, this was toothbrush tachycardia, which he crossed off VTAC. And he goes, this is toothbrush tachycardia. So it was a good lesson, right? Check your patients, check the leads. And I can see that you guys in chat, Vanessa's like, oh yeah, check the patient. Good. See, so you would have passed his test. Michelle said she had one in the unit, looked like Vfib, all the alarms are going off, but patient was climbing out of bed, shivering and cold. Yeah, check your patient. Right? Good, Michelle. See, thank you. So how can you learn more? Let's talk about that. And I'm glad, Michelle, that you are here because I'm excited to announce, well, I've announced it already once or twice, I think, but I'm really excited to announce that we are doing a live workshop, okay, in May on the 22nd. And we're going to have stations where we do hands-on with you with a whole workbook of practice strips. And we're going to do this on May 22nd. We're doing it in person. We have a couple in-person spots left. Michelle's flying in, Megan's coming in. We've got Coach Sean flying in. We've got Coach Samantha flying in. We've got a bunch of really cool people coming in. But we're also offering virtual tickets. It's going to be streamed live from a professional studio where you can sit with us for 8 hours and go through all the breakout sessions and learn more about basic arrhythmias. You can learn more about basic 12 lead. You're going to get to do hands-on stations with all of us. And so we can give you that one-on-one interaction. And you also get 8 hours of CE if you're a provider. Yay, Stephanie. So we will be doing basic EKG review at that class for sure. In fact, Michelle is doing a big chunk of it. I'm doing a big chunk of it. And we'll also do a dedicated arrhythmia class. So you can actually get your in-person spot. I have a couple left if you want it. Those are on the website, conqueringcardiology.com. But we have a bunch of virtual tickets that have just opened up and we are announcing today. So you can go grab your spot for only $99 and be virtual with us. And yeah, okay, yeah, but we're doing virtual. And the cool thing is it's going to be done in Monterey. So we're going to be, this is really cool. We're going to be like 5 minutes from the water and we're streaming out of a professional studio. So the grade of imagery and video, and it will feel like you're in the room if you're virtual. So we're so excited for that. So if you want to join us for 8 hours of continuing education with basic baby steps going all the way up to hands-on, where you walk away with the high risk findings and get to go through some patient scenarios, then join us in the class. Coach Michelle is going to be there, as I said, Coach Megan, Coach Samantha, and of course, I will be there. And we're also going to do a special segment called 2 minutes, 2 slides, 2 questions in person, and it's going to be a contest. So you're going to get to vote for who had the best slides, and whoever wins will actually get a prize. So that's kind of cool. So this is a really exciting thing. You guys can go to conqueringcardiology.com and grab your virtual ticket if you want to join us. And if you are free next week, we are also meeting in the 5D EKG group, which we are here now. We're going to be meeting for a 5-night challenge where we're going to go over a little bit more basic EKG stuff. Not going to really do any arrhythmias. That's why we kind of did an arrhythmia warm up tonight. And we're going to do 4 high risk EKGs We also have some bonus lectures which are coming up, which are super exciting. We have a chest pain guideline update with Mike Sharma, PAC, which is coming up on next week, Tuesday, as the bonus. We're doing Thursday. And on Tuesday, we're doing a basic arrhythmia primer with Coach Gary, where he'll do some dynamic strips, not basic strips like we did tonight. They'll be flashed up on the screen and you guys will get to guess dynamic rhythm style. And then we're going to do a game at the very end to wrap up with Coach Michelle, where she's going to quiz us on all the things we learned in a game. So it's totally like an awesome learning environment. So we're excited about that as well. So have a good night, you guys. We've so enjoyed hanging out with you, and we'll be seeing you very soon, hopefully in Monterey, because we want to meet you guys, but if not, virtually. And then we'll definitely see you next week in the 5D EKG group. Again, you can go to conqueringcardiology.com to get your virtual ticket, and we'll see you guys soon. Have a good night, you guys. Bye.